Let's keep the blood pressure 100 to 110 systolic, please, as long as you're comfortable with that. Once we get above 110, we get spontaneous bleeding. All right, and we're going to be performing in a patient today who's had prior fusion done elsewhere. The fusion did not go well. The implant, to me, looks like it failed to fuse. And our patient now has problems above and below the old fusion, as well as what we call a pseudoarthrosis or failed fusion. The pseudoarthrosis or failed fusion is at C5-6. There's probably the platysma there, and we're through the platysma. And we're going to fix the disc above the fusion and below the fusion, as well as remove the implant and refuse the 5-6 disc, which they put some weird implant, and that's why I don't like weird implants. I like to go with what's tried and true and works. And that weird implant basically didn't work to fuse. So she has a failed fusion, and she's having a lot of problems as a result with neck pain, headaches, pinched nerves. So we're going to replace the old fusion device with a new, better fusion device, and we're going to fix the discs above and below. We're cutting through the platysma muscle. You can barely make it out. It's a very thin layer here. And under the platysma is connective tissue. And what we're looking for here is the sternocleidomastoid muscle, which is going to be right around here. And then medial are all the strap muscles. So now most people don't see me doing fusion surgeries because I do a lot of endoscopic surgery now. I rarely ever do fusions. But this was not a case that I could do a endoscopic surgery to fix because this patient has a fusion already with a metal device at C5-6, and I can't do anything at C5-6 with that metal device. But I could fix the discs above and below with laser, but she wanted to have it all done in one shot. So we're fixing everything with open surgery today. Okay? So the key here is to find what's called the plane, bipolar. And the plane is the path. It's the path between the tissues that we need to go down in order to get to the area of the spine that we're working on safely. And the plane is sometimes not easy to find because the patients have prior surgery, like this one. They have scar tissue in there from the prior surgery. Are you at my first person view?
Yes, sir, you are.
Yeah, so you're looking through my GoPro. Bovie, pick up, please. Are you looking through the GoPro?
Yes, you are.
Yeah, so it's first person. You can see everything clear?
I can.
Good, all right. So you can see all these adhesions here. These are adhesions from her prior surgery where the surgeon, and it wasn't me, some other surgeon went in and did this surgery, and so there's a lot of scar tissue here. The adhesions are in this area. I'm going to try to work above the adhesions and find our plane to get down to the spine. And like I said, with all the scar tissue from the prior surgery, it can sometimes be difficult to do. I need you to lift up. But I have Dr. Patel assisting me, and I need to find that plane, which is going to be medial to the sternocleidomastoid muscle and lateral to the strap muscles, okay? Like right around here. And what makes this look weird is the fact that there's prior surgery. So as you're doing this, you want to try to stay out of the omohyoid, just above it. See where I am right now? See how I'm spreading with my scissor? I go in with the tip, I push down a little bit, and I spread. So what I'm doing is I'm trying to find that proper plane to go down to the spine. I'm feeling the Adam's apple here, and I know there's a crease right here that runs like that along the length of my finger, and that's what I'm trying to develop with my technique. So some people say, oh, Dr. Deuk, I didn't know you do fusions, but yeah, I've done this type of fusion surgery in over 1,000 patients. Think about that, over 1,000 patients, ACDFs, And each one I've done about 2 discs on average. So I've done 1,000 patients and over 2,000 disc fusions in the 26 years I've been doing surgery, since I've been a doctor. So it's not like I don't do these types of procedures. I do, but we try not to do them because fusion surgery is so damaging. Look at all the damage to the tissue here. Right, Dr. Patel? So the endoscopic surgery, none of this is happening. None of this scarring that's going to happen in here that you already see from the last surgery, that's all scar tissue there. None of the scar tissue would be there if we did the laser surgery for the first surgery. And honestly, she wouldn't need the surgery if she had done the laser surgery first. Fusion creates a lot of problems. It creates scar tissue and damages blood vessels and the esophagus, sometimes the trachea. And look at just the tissues are all stuck together. Normally they just separate easily. So all this trauma that has to be done in order to get down to the spine with a fusion surgery could be avoidable. All this cutting and bipolaring, all this stuff is totally unnecessary when you do the Deuk Laser Disc Repair procedure. Okay? So let's see a lipless. So I think I'm finding the plane between the sternocleidomastoid and the, right there, you see that? See how you can see fascia, the white fascia? That's a good sign. You're in the right place. Again, a lot of trauma here. Why? This is standard. By the way, my ACDFs are the most atraumatic ACDFs you'll ever see. And nobody else will show you, Kitty. No one else is going to show you an ACDF because honestly, surgeons just don't have the chutzpah to do it. They're afraid of a complication happening, which a lot of them have complications. Yeah, could a complication occur with this surgery? Absolutely. But I'm not afraid to show you the complication. Complications themselves are not malpractice or anything. It's what you do with the complication, how you manage it. That's what could be a problem for the patient and the surgeon. So I feel pretty confident that if we do have an issue, bipolar suction, that we can deal with it properly. But this is a really difficult case because of the prior fusion that was done on this side of the neck. So I'm going in on the same side of her neck as her prior surgeon, who went on the right side. And we're just above the scar right now. And all of these tissues, Kitty, are stuck together because of her prior surgery. And had she not had that fusion, all of these things would just open up like a door, just opening. But now I have to find my way through all the scar tissue here and get down to the spine safely. Now remember, I'm also passing the carotid artery. The carotid artery and jugular vein are right there. And I need to go medial to them, okay? So if you're a surgeon and you want to do this kind of surgery, make sure you go medial. Believe it or not, some surgeons don't know that. They're just horrible surgeons out there. And they make all kinds of mistakes. And patients pay the price. They suffer as a result of the poor technique. So here we're almost there. This is how I do it. I use a Kittner. It's a little cotton, right? And we call it kitty, and we just sweep it. Now this is a technique I learned in residency at University of Florida in Gainesville, where we had the best training in spine and cranial. There's a carotid artery right there. You see that? This little thing right here is a carotid artery. And there's a lot of scar tissue from the prior surgery. Okay, so the spine is right here. I can feel it. I'll show it to you in a moment. I've got the trachea here, and I'm going to push it that way towards Dr. Patel. I've got the esophagus just behind it. It's going to go towards Dr. Patel. I've got the carotid sheath and its contents coming this way, which is your vagus nerve, your internal, your carotid artery, your internal jugular vein, okay, that drains the head. Hold this. Now, Dr. Patel has done a few of these cases. Look at the blood here. We're not getting a lot of blood. We're getting very little, okay? But the reason why we're even getting any of this blood is oozing from the surfaces of the scar tissue from the prior surgery. Normally we wouldn't have any of this. You need to be over there. All right.
45 and 50, what do you think?
I think it's going to be a 45 and 50. Luis, you're the best. So here's the front of the spine. And by the way, see all this white stuff? Let me have a pointer or something. Look at this web of white tissue. That is all scar tissue from the prior surgery. Okay, none of this should be here. And look how it oozes and bleeds. That's why we want to keep our blood pressure down. Systolic around 100 to 110, as long as the patient doesn't have a reason not to, like carotid artery stenosis, which we wouldn't be treating them right now without that. With that, they would have that fixed first. And then cardiac disease, coronary artery disease, all those things would preclude us, or very, very high blood pressure normally would keep us from being able to lower the blood pressure to where we want it. Now I got to bipolar the scar tissue so it doesn't bleed too much. And I'm going to have to cut it with my scissors. So that's what I'm going to do. I'm going to use a combination of sharp and blunt dissection to get down to the spine. I know exactly where the carotid artery is. It's there, okay? So I'm not going to injure it. I'm right on the spine. But what I still need to do is expose the rest of the spine. And that's what I'm trying to do. Now, the further up we go, that's the anterior longitudinal ligament there. But down here, this is where the old surgery was done. And there's going to be an implant here in the spine that we have to find and then remove. So, thank you, Dr. Patel. I have my partner, Dr. Patel, here working with me. Scissor. Yeah. And I have Luis. Yep, thank you. Just give me a second. I'm actually working. This is the right way to do this, by the way. So the problem, folks, bipolar, is that surgeons get different training at different training centers. And there are about 120 neurosurgery training centers in the United States. Worldwide, I couldn't tell you. Probably well over 200. And every single center teaches the surgeon a different way to do this surgery. The way I do it is the way that I've learned over the last 1,000 surgeries is the best for the patient, for their recovery, for their safety, and for the effectiveness of the surgery itself. Okay? So all the techniques I use are basically mine that I have developed partially from what I was taught, that I've modified and made better. So everything I do is actually well planned and thought out and has been done before by me and is the best way to do it, okay? So I'll give you an example. I'm going to cut this tissue because it's keeping me from retracting and getting a better view of the area below the implant. If I don't do that and I just leave it, then we're going to put too much pressure on the esophagus on this side here where Patel is, and that's going to cause dysphagia after surgery. The patient won't be able to swallow their food or liquids. And that happens all the time with this kind of surgery because surgeons don't understand it. They think making a smaller incision and a smaller hole reduces the risk of postoperative dysphagia and odynophagia, which is painful swallowing. It actually increases it. You know, and I was taught when I was a resident, make a smaller hole, right? You're going to have less chance of having swallow problems in the patient. That was the opposite of the truth, but I had to figure that out because I started thinking about it and I thought, the smaller the hole, the harder you're retracting on the esophagus to get the visibility you need. So when I started to make the hole bigger, which goes against what you think naturally, then I realized you get to retract less on the esophagus. And then the patient stopped having trouble swallowing afterwards. They have a little bit of a sore throat, but I mean, there are times when we would have patients that we'd have to readmit them to the hospital because they were salivating. They couldn't even swallow their saliva. It hurt so bad. And we put them on IV Decadron, every 8 hours to reduce the swelling for about, you need to come south a little bit. Yeah, give me a retraction here. We put them on IV Decadron every 8 hours to reduce the swelling of the esophagus from the retraction. That was purely from retracting. All right, this is where there's heavy scar tissue, so you got to be really careful. My technique is to go in and spread. Go in and spread. And this is a standard surgical technique. I didn't develop that technique, but I learned it from the surgeons that trained me. vascular and cardiothoracic and neurosurgeons, of course. It's pretty standard to learn how to use these types of scissors. Anybody know the name of the scissors? Anybody in the audience know the name? Oh, who said that? Oh, not you. You can't give the answer. By the way, for those of you who don't know, we're broadcasting this surgery live around the world, as we do all of our surgeries at Deuk Spine. And we have people watching on Facebook Live, Twitter Live, which is the Periscope platform, and of course YouTube. And so if you have questions during the surgery, feel free to ask. But basically, we're just teaching here and hoping that people can learn a little bit more about spine issues, spine surgery. So if you have any questions related, Kitty, to the spine, I'll take them, okay? So right now, I'm just freeing up the trachea and esophagus on this side from the carotid artery on this side because they're scarred together from the prior surgery. That's what all this scar tissue here is. And I got to do it carefully because if you damage the carotid artery, it's bad, okay? Really bad. The patient can die from a stroke, and we don't want that. Or they could bleed to death. So fortunately, I've done this many times, and that's why I'm broadcasting, so other surgeons can learn from my technique and do things the right way. It's very easy to get in trouble on a revision surgery like this. So, you have a question? Any question there, Diego?
No, we do not.
All right, so I'm sweeping the soft tissues. This is what's called the retropharyngeal fascia right here, sweeping it off the spine. And our implant is going to be somewhere around here, okay? So let's see, go north. Oh. We are going to use an x-ray soon to figure out where we are. But that's pretty much the spine. You can see the, what is it called? The longus colli muscles there. All right, so I got to figure out what level we're at because that's going to determine how much more exposure I need. Let me have a localizer.
Yes, sir.
I'm going to use a little piece of metal and go into one of the discs. I'm thinking this may be right above the old surgery, the fusion. So let's see. Come on out. Let's get an x-ray. Yeah, I'm going to move out for a second. All right, so for those of you who joined us just now, this is Dr. Ara Deuk-Majan. We're at the Deuk Spine Institute. Our patient has had a prior anterior cervical fusion. I don't think the surgeon took out all the disc at C5-6 where her fusion was done. There's a lot of disc still there and it's pushing on the nerve, so I'm going to go in there and clean it all out properly, okay? But I need to know where we are first, so that's what we're doing. We're getting an x-ray to check our localization of where we are. All right, where are we? 2, 3, 4, 5. You agree, Luis? Let me come look at that a little better. Stay there for a second. C2, I can see on the x-ray. Have you switched over to the x-ray there?
Yes, we're seeing it.
I need to see it better. Who has lead? All right, come on over here. Okay, well, behind me. Okay, hold this up to here, and with your right hand, and pull the shoulder down with your left. Patel, you have lead? Yeah, give me a second. And let's get another shot. You need to zoom in a little bit more. Bring your fluoro closer to the patient if you can. There you go. Let's try that. And somebody's hand's in the way, their finger. Try to move the fingers further down the arm and grab it and pull. And shot. Better? All right, perfect. Stay where you are and let me get in there. Okay, you can move out. Move the fluoro north. We're good. Move the fluoro north. Patel, you agree? 2, 3, 4, 5. You agree? 4, 5? Yep. All right. So that is C4, 5. Bring the table down, please, doctor. Yep. All the way down. All right. So that should be the most of our fluoro. So this, I need his first. This is, I'm going to use a lift retractor on Dr. Patel's side. This is a handheld retractor. We haven't put the self-retaining retractors in. Hold that. Let me have mine. So I haven't taken the localizer out, but that's still in the 4-5 disc. So what I'm going to do is I'm going to take this out, take that, and because we're fixing this disc as well, I'm marking it. Now some doctors will mark it with a blue dye or something. Bad idea. Those dyes can diffuse along the tissues. I mark it with something that will never diffuse, and that's a burn mark, because we're going to go in there anyway. So that means the disc with the problem, look at all the scar tissue this device has created, is right there. That's where the implant is. All right? And then that means the next disc we're fixing is below that. Suck, please. Down here. Right about there. So we are not far enough south for the exposure. So I need to come back up to the surface up here where the platysma is, and I need to open this a little more. So Bovie. So that's why I did that. I want to see, am I done with my exposure? And the answer is no. So you can see I went through the platysma. There's fat underneath. I'm probably going to get to the omohyoid muscle. It may have been sacrificed in the last surgery. I don't know, because I wasn't there. And some doctors don't understand not to sacrifice the omohyoid. It's hard to say. It looks like it might still be here. I can't tell. Either way, I need more exposure down south. South is towards the feet. That's what the terminology, north and south. North is to the head, south is to the feet. So, are there any questions from our audience?
No, there is not.
You're watching a revision at C5-6, anterior cervical discectomy and fusion. We're adding in, that's the omohyoid. We're adding in C4-5 and C6-7. So one disc above and one disc below, because this patient has developed adjacent segment disease from their fusion. Adjacent segment disease, adjacent means adjacent to or next to. Segment means the next motion segment, or a segment of motion in the spine, which is a disc. Disease means the disc is injured and causing symptoms, both injured and causing symptoms. So this patient has adjacent segment disease that is one disc above and one disc below the prior surgery. So that's the 4-5 and 6-7. And we're also going to fix the 5-6 as well, because they didn't do a very good job there. This is all scar tissue. You're watching me bipolar and cut. Okay? You always want to bipolar it because it bleeds otherwise. We've lost 5 mils of blood. 5 at most. All right, Kitty. So far in the surgery, we've only lost 5 cc's or 5 mils of blood. Now look at that beautiful exposure we got without having to sacrifice this omohyoid muscle right here. And you can still see the carotid right here. That's the carotid artery. And just between it and the internal jugular, right in here, in that place where I'm retracting, that's where you're going to have your vagus nerve. The vagus nerve, of course, is the parasympathetic supply to the chest organs, like the heart. All right, so there's 4-5, 5-6 is there, and 6-7, Dr. Patel, move south. Don't crush the esophagus. Yeah, let me see. There's 6-7 right there. Hold this here. And look at the scar tissue there. You see that? Yeah. Hold it right there. Hold it there. Let me have a kitty. Yes, sir. Look at that right there. All these little tendrils of attachment is scar tissue. It's stuck on the ALL, anterior longitudinal ligament. Okay? All right. So, making good progress. What do you think, Bada? You think we're good there? Let me see. All right. I think we got enough exposure there. So you can see the disc. Stay there. Bobby, you can see the disc right here. I think that's the disc. That's the C6. C6-7 disc and C7 vertebral body. So we only need to go halfway down the C7 vertebral body because that's the last vertebral body we're screwing into. And then up here, go up, we can see the 4-5 disc, and that means that's the C4 vertebral body right there. We only need to go halfway up. You never want to go past halfway up the vertebral body on both ends because you'll get into the next disc and you'll cause problems. So let's expose the implant.
Dr. Duke, we have our first question.
You have a question. Look at the metal. See the flames right there? Woo-wee. That's the implant right there. And it does not look fused. It does not look fused. Look at the movement. Right there, you can see the movement right here. See that? There's no fusion. So it's not fused. We have a pseudoarthrosis confirmed. I need something like my little tool, my little Penfield 4. Pseudoarthrosis confirmed with hardware failure right there. You can see the bone is moving relative to the implant. I don't know if you guys can appreciate that. All right, our first question, go ahead.
Yes, we have a question from Facebook. Does scar tissue cause more pain?
Does scar tissue cause more pain? It can, but it usually doesn't. It usually does not. Scar tissue gets blamed for a lot of things that it doesn't deserve to be blamed for. But remember, scar tissue is normally, it's not normal in terms of the scar tissue in this area shouldn't be here, but it's unavoidable when you do open surgery. You're going to have scar tissue. Scar tissue is collagen mostly. And when when I do the laser surgery where we have a hole in the back of the disc called the annulus, the annular tear, well, that hole gets filled in with scar tissue. Scar tissue is collagen. Well, the disc itself is already made out of collagen. I mean, the annulus fibrosis is. So you're actually replacing the annulus fibrosis with scar tissue, which is the same thing it's normally made out of. That's the only real place in the body that scar tissue is actually not bad, is with the Deuk Laser Disc Repair procedure. Because you're repairing the annular tear over time with scar tissue, which is the same thing the annulus is already made out of. Right, Dr. Patel? So every other tissue in the body that gets damaged and has scar tissue formed, scar tissue is normally not part of that tissue. It's only there because of the damage. So scar tissue does not cause pain normally. But look, what it's scarred to right here, okay? What this is, I'm touching this. You see this thing I'm touching, this red thing? That's the back of the esophagus, the swallowing tube. So it literally scarred the swallowing tube to the spine and to the implant. That's why you don't want implants and you don't want open surgery like ACDF. There's 1.5 million ACDFs done every year in the United States. All of them could be avoided, virtually all of them, if we did endoscopic surgery instead, where there is no scar tissue, except in the annulus where it belongs. All right, so we are past the implant now. You can see it right there. It's actually, the implant is sticking out of the spine. You see that step right there? That's the bone of the spine. There's the edge of the implant. It's pushed out. Huh? There is. It's a weird plate. I'll show it to you. But the implant has been extruded out of the spine by about 5 millimeters. So we have failed fusion, C5-6, and hardware failure with partial extrusion of implant. Where is she? You got to document that in the op note, okay? Partial extrusion of C5-6 implant, 5 millimeters. All right, so there's the 6 bone, and this is the 6-7 disc. We're fixing the 6-7 disc, right? So we got to go here and take that disc out. I need to see okay, stay right there. I need a sweep. There's more scar tissue right there. I got to sweep it off. The safest way to deal with this scar tissue, scarring the esophagus to the back, to the front of the spine, is sweeping with the kitty. And it requires not just this movement, but you see I do a rolling movement. It's like a rolling sweep with pressure. And that way you don't damage the esophagus. That is the esophagus right there. So it looks like we're struggling to get south, are we? Huh? You think we're okay, Bobby? All right. Well, let's see if we have to struggle anymore. So I need you to not just toe in, but I need you to toe down. So like slide down like that and hold it down there. You see that? I'm actually pushing down. Okay? Yeah, this is hard. There's no easy way to do these types of surgery. And they're so traumatic to the patient's body. But this is what all the spine surgeons around the world are doing these days, this type of surgery, except for us. We do the endoscopic surgery. There's a little emissary vein. Suck it, please. Let me see where the disc space is there. You may have some bone wax on a kitty.
Yes, sir.
So rather than keep boving that, because I'll get into the disc below, which is the C7T1, which I don't want to do, I'm just going to put a little bit of bone wax on there, and that will stop the bleeding. Okay? All right, let's come back to my side. Let's come back to the implant. You can all see the implant better now, right? Right there, that implant.
Yes.
And again, it's failed to do its job. It's pushed out of the disc space. So those metal things that they used in the x-ray, you can see them. Those metal tines did not hold it in place very well. And it's probably pushed out because the fusion failed. So implants are not designed to last forever. Instrumentation is not designed to last forever. They test all this stuff in bone as part of the FDA approval process. They test it with like 1 million cycles of movement. They put it on a machine. Hold this, please. They put it on a machine, and the machine goes with the implants right here. So they put the implant in. Okay, this is the implant between the bones, and they have this machine with screws on like some kind of an engine, and it goes tick 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 tick, and each one of these is called a cycle, front and back, all right? And they do 1 million cycles. So they leave that machine on for a week, and then they come back and check the implants and see, hey, I need you to hold this, and I need the pen field. They check the implants and see if they got loose, all right? And then they report if they got loose or not. Well, this thing has failed. I think she just had it put in, right? Go north, please. What? So just a couple of years ago. So it's already failed in a couple of years. That sucks. But the main reason it failed is that she didn't fuse. These implants are not designed to last forever. They're only designed for 1 million cycles. And if they go past that, suck please, then what's going to happen is they're going to fail if the spine hasn't fused by then. So the idea is that your bones fuse together at that implant level, which hers did not, probably because the implant wasn't a very good implant to begin with. Okay, so there's the C4 bone right there. There's the bottom of the C4 bone right there. There's the C4-5 disc. The C5 bone is there. The C5-6 implant. The C6 bone is there. The C6-7 disc is there, and the C7 bone is there. So I just got to finish the exposure. The exposure is the part of surgery where the surgeon gets the area he's operating on, or she's operating on, visible for them to do their job. And I'm not done with that yet. Exposure is the term we use in surgery. Unfortunately, it's also the term used for sickos that go to the park in trench coats. Go south. See, I got a chuckle out of one of my employees over there. I don't know, who's chuckling over there? Oh, of course. Amy is so generous with her laughter at my jokes. Right? You want to make me feel good about my jokes. I appreciate that. It's very sensitive and thoughtful. So yeah, the implant is extruded at the top, and the bottom is still there, but the top is pushed out. Okay, suck that. Now, this is what's called the longus colli muscle, and that's what I'm taking off the spine. I need to see here. Whee! All right, right there. Yeah. So we are exposing 3 discs, 1 disc, then the implant disc, and then a 3rd disc, and the bones on both sides of those discs. I need you guys to give me that exposure right there. Hold it there. Don't let it move. No, you're letting it move. Pull it towards you, towards me. There you go. Perfect. That 1 millimeter actually makes every difference in the world, Luis. You know what I mean?
Yes, sir.
Joe Green? You know who Mean Joe Green was?
What?
Do you know who Mean Joe Green was? Anybody know who Mean Joe Green was besides me? I always say that to my kids. I'm like, you know what I mean, Joe Green? And my kids look at me funny. Let me bipolar those vessels right there. Come south a little bit or just up. I need a bipolar. See where they are? Right there on the wall. Patel, they're right here on the wall. Yeah, bipolar. Otherwise, they may pop open and bleed later. Bipolaring is cooking. It uses plasma. Same thing Dr. Patel uses in his radio frequency ablations. So at Deuk Spine, we use two types of energy, plasma and laser, for certain applications. All right, that's good. All right, so everyone see the toe in? Everyone see the carotid artery right here? Right there, that's the carotid artery. It feeds 40% of the blood to the brain. 40% per carotid artery. Pretty cool, huh? So that's 80% for the two carotids. Where does the rest of the blood come from? Anybody know? Vertebral arteries, that's right. There's two vertebral arteries. They supply 10% each, normally. All right, here's the longus colli muscle, and what runs inside the longus colli muscle we have to be very careful with. The sympathetic trunk. The sympathetic trunk. If you damage it, the patient will wake up with a big pupil. All right, hold this here. Yeah. All right, so I think we've done a pretty good job of exposing. We need to get this thing out. Okay? Look at the movement. Do you have the tools I need?
Oh, yeah.
All right, let's try it. That's good, Dr.
You don't
Patel.
want to actually put the retractor, it's just for you to work on that?
I think I'm going to try to get it out before I put the retractor.
All right, so.
Oh, so no. Where? No, I want those metal things that you showed me the other day.
So you need to remove that center plate, and then you're gonna see the hole that then, you know what I'm saying? You need to remove that center plate.
How do I remove the center plate? Anybody have a tutorial?
Just like that, you have to remove it
Like in between? So this is an implant that we don't normally use. Do you know the name of this thing?
It's a thing, Amy, it's what's the name? Seamless? Yeah. So there's yeah.
Oh, what kind of plate? Burba? Will you pull it up?
So that plate in the center exposed two holes, and then we use this device.
So how do I get that plate in the center?
So you can drill it. The
No,
left side
I don't
you can
wanna-
drill it, and,
I don't
close the
really
hole.
want to drill it.
Yeah. Or just use this.
What a mess.
It's right there. Yeah.
Who has the CAT scan? Do we have the CAT scan I can look at? All right, let's put some irrigation in here. Come out for a minute. So the plate we're taking out, we don't ever put in, and it's one of those obscure, weird plates that probably, if I had to guess, the surgeon's getting a kickback for putting it in. Otherwise, there's no reason to put it in. And long story short, there's literally 100 different plates, and they all have different, ways of putting them in and fastening them and keeping the screws from backing out. So I've never put one of these in. I probably never will. But that said, we're just taking it out. So because I've never taken one of these out personally. I think it's a newer design. Keep going. Keep going. Keep going. All right, so
There was couple papers that I have right here.
let me see.
That show, okay, that's the one. Yes, that's the one. That's the easy
All
one.
right.
Yep.
So there it is, removal areas. Removal areas. Wow. I see, there's a screw. All right, so how do we remove the face?
That's what the host told, or she told me to drill there.
Are you kidding me? But how do they put it on there? Oh, so that's a back out mechanism.
Yes.
It prevents back out. They really don't have a way to do this. This is insane. In other words, the company that manufactured this, I guess, planned on none of these plates ever coming out, so they don't really have a very good way of getting them out. Hold this here, please. Gentle. Irrigation, suction. Well, it looks like they didn't even put that part in. Wait, what is that screw hole right there? You see that?
If there are two holes, that's fine because we pull that.
Suck, please. Yeah, there's...
If you see two holes there.
Is there a hole in your side, Patel? Let me see. Let me see.
There
So-
should be one north and one south hole.
I need you to suck that. Suck on your side. There's... There's a hole. Hold this here. Let me have a pituitary or something. Yeah, that's right there is perfect. Toe in. Yeah, right there, too much. You release this muscle and now it's blocking your side. Okay, you need to be underneath. There you go. Get underneath it, but not too much. I need to see if there's a hole right here. Is there a hole there? No. By the way, that right there is the esophagus, so you want to be super careful. There's a hole on my side that's threaded. It looks like it's threaded, so that's where the locking screw is. I need the driver to get it out.
Yes, sir. So you do this one. So you hook this, and then this is gonna pull.
Pull what?
So this is going under the hole, and then just rotate, and this is gonna pull out there. See? Yeah. So that's what.
But isn't there a screw inside the hole right there?
No. This is just two plates going up and down. So when we remove the center plate, you're gonna see two holes there. That's why we need to, yeah.
All right, let's put the self-retaining retractor in.
Yes, sir. So that's what, yeah, that's what. All right, 45.
Some of these fucking companies really piss me off. Wait, you always give me the longer one first, okay? That hasn't changed no matter how few of these surgeries we do anymore, okay? Let's see. Patel, you can come out. Yeah. Hold on, it's got to stay underneath the longest collar, so right there is fine. You got it? And then I'll do my side. I mean, part of the problem is the plate is, like, the cage is rotated towards you. Oh, she's got a big chest. That's going to make this a little more difficult to get it in, but we got it. All right. Remember, the exposure is the key here. If you don't do the exposure right, then you can't do the surgery right. And the fact that we took our time and did the exposure right, oh, not too much force. You'll wiggle it right out. Wiggle and up. All right, so there's what we're dealing with. You all see that? And that hole is angled off to Patel's side, even though the surgery was done from this side. So it's a real cahooter. All right, let's see that thing.
All right, so it's gonna be there.
So why do I absolutely hate this stuff? Because this implant was made for one purpose, to make somebody rich. And it's a horrible system. Horrible.
The hook go into the hole, right, like this, and then you tie it with rotate it. So the hole is very
Yeah, all right, so that's not going to work, okay? Give me those papers, please. I'm going to show you, Luis, what the problem is. Fuckers. Okay. Luis, look.
Yes, sir.
You see that hole right there?
Yes, sir.
There's a screw that goes in that hole, right, to lock the plate in? All right, what's that? What's that? What is that?
So yeah, that's the way to. That's how they explained to me. Just remove that plate, and inside that plate, behind that plate, you're gonna see two holes. Can you?
Hold on, hold on.
pass that to us? There you see. So you see one. You see that? So then you hook this device into that hole, rotate it, pull, and then hook up, and then pull, and then both of them come out.
Yeah.
Sometimes you can grab
But
it
what's
with
in the
pocket.
front? Go back to the front. Okay, that's what we're looking at right
Yes,
there.
Yes.
So what do we do from
So
there?
you need to, you see these around, I'm sorry.
No, no.
So these around, like this on top
Yeah.
of the water, you're gonna, or you can drill or also turn those.
Okay,
and you see
move
those.
back a little
Yeah,
bit.
and then you see those holes. Those are the one, that's the key that you want, that holes, right there. So we
These
need to,
holes?
yeah, that's the one that we need. We need to remove that on the top and on the bottom. And then see those holes, that's what we need.
Okay, so you're removing this to
Yes,
expose that.
Yes, yes.
Let's see. Patel. How's the, oh, no. Why did you do that? Why did you do that? Why did you open this more? You never do that. You're putting too much traction on the esophagus, Bada. My God. Please don't do things like that without me. Yeah. This is not a giant visibility thing. Everything is done through a small working area. Let me have that osteotome.
Yes, sir.
There's some kind of a cover here, and I can't even see that there is. I have no idea what they did there. Let me have, you hold this down, rock it, yep. Smell it.
Yes.
There it goes. Look at that. Suction,
want the
please.
cover?
You need a sucker, dude. Look at that. That thing just came right off.
You want a copper?
Oh, there it is. Right there.
And then the other one.
Come on. Either get it or don't. Let me get it. Pituitary. There you go. All right. Now.
Pituitary?
Not yet. Come on. You got it. Move your hand, please. This, you're twisting it. Don't let it twist. If you push like this, it twists like that. If you pull like this, it moves. You got to just hold it steady against the spine, down and hold it. Don't let it move. Mallet.
Ready?
You're not going to be able to see as much as I do, Bharat, so don't try. Okay? Just see enough that you can see the retractor's not moving. This is just difficult because I don't have a scope in here. What a piece of junk. You have to break the device to get it out. I've never heard of anything so stupid. For all you surgeons out there watching, don't stop putting things in patients just because it makes you money. Do what's best for the patient. Put good implants that are not going to hurt the patient. Let me have that other thing. The hook.
Yes, sir.
I don't even know if this is going to work.
So there is, yeah.
It's the stupidest thing I've ever seen in my life.
And then what? Yeah.
These are all gimmicks, okay? Robotic surgery is no different. It's a gimmick. Right, where is your blade, Bada? Where is your blade? Let me have a pointer. Where's your blade? Okay, where's the middle of your blade? Right here. What should be right here? This. Okay? The middle of the blade is where we're operating. You're pushing the whole thing north. I need you to at least do that. Let's try a coker and see if I can, or even a needle holder and see if I can get it out. It looks like there's a little thing right there. Almost like a place I could hook it.
Yeah, so that's, yeah. That's
I understand what you're saying. The question is, can you get into the hook, into the hole? Guess why you wouldn't be able to get into the hole? Huh? Do you know?
Huh?
Why would you not be able to get in the hole? Because bone grows into there. There's one plate.
There you go. Nice.
Okay? Maybe I'll be sued by this company, but I don't care. People need to know the truth. This stuff is garbage. And I have no respect for surgeons who put their money ahead of patients' health by putting shit like this in. Let me have a
Yes, sir.
coker. Honestly, this is why I hate most doctors, because they do stupid things like this. This device should not be put in my opinion. It's garbage, and it just creates a hazard for the patient, for the surgeon to have to go back and take it out. And by the way, for those of you wondering, there aren't many surgeons like me that will actually spend their time going in and taking this stuff out, okay? And the reason is because we got better things to do than to go and clean up someone else's mess, some irresponsible person's mess, you understand? That's how I feel about it. But I'm doing this for my patient because I know there's nobody else out there that will do this surgery, because it's such a pain in the ass to do and risky. There's always a risk of getting sued for complications. So finding doctors that are willing to do this kind of nonsense, fix other doctors' garbage, is going to get harder and harder for patients to do in time. So anybody out there that wants to develop a skill of doing it, let me have the osteotome again. That's really interesting. Mallet.
Can I have more boneless too? Boneless?
Bone wax.
Oh, you have some here? Okay, perfect.
Let me have the needle holder.
Yes, sir. Ready?
So just so everybody knows, there was a failed fusion here with a hardware failure, probably to blame. Almost there. I feel like a dentist pulling out shit out of people's jaw. All right, so now we got the cage that needs to come out. Is there something I can screw into this cage to pull it out? I mean, there's a screw hole. It looks like that's how. What about the tool to get the cage in and out?
That's what she told me about to use. We can do it with a coker.
A coker. How nice. So she didn't give us the tool. Why not?
No, we don't have
But why didn't she give us the tool? Huh? I don't understand. Yes?
Yeah, she brought everything to pull that.
Yeah, but there's a tool to put that cage in. Where is the tool that's used to put the cage in? Do they have something?
No, she just, yeah, with that, she told me with that.
So nice.
That's the only,
So nice of her.
Yeah, that's the only thing that we
Mhm.
should need.
Great.
That's
That's the only thing we should need. Because you're going to fail anyway. So you won't even get to this level.
what do you need, sir?
I need something like a coker, I guess. I don't even think I can fit a coker in there. I don't have a tool that's going to fit around this thing. A little mosquito? No. What about, we don't have a little screwdriver, huh, that can go in there?
We can.
A screwdriver? What do you have? You have the universal removal set? Let's try a little screwdriver I can screw in there. It's probably like 2 millimeters. No. The problem is it won't generate enough force on the pinch. It'll just bend it. So let me see that. That's not a screwdriver. We need an end that threads, that we can thread into. Hmm?
We can,
There's something I've used before. I don't see it in here.
it's probably on the universal, sir.
Where's the universal? We don't have it?
Yeah, we have it, we have it.
You just don't want to open it?
Yes.
Wait, you see that right there?
Yeah,
What screws into
yeah,
that?
that's the inserter.
Don't open that tray yet.
Yeah. We can,
Yeah, let me see the inserter. Oh, that's it?
yeah.
But there's one without. There's one without this metal sleeve. Oh, there. Let's try that. Hey, you're getting to watch how surgeons get to MacGyver it. You know? I think it's going to be a little bit too big. Is there a skinnier inserter? Hey, it's going in. Oh, yeah. And look at that thing wobbling around. What a piece of shit. Oh, hey, last surgery, somebody was saying that they didn't like my surgery being broadcast because I cuss. I'm so sorry. I didn't mean to offend you. I'm not Mr. Rogers. I'm Mr. Real. So get real. Don't offend a surgeon by telling him you don't like the fact that he cusses.
I don't need it, just stand by, okay?
Oh, it's just scarred in. That's interesting. At least we've captured it. I just don't think I can extract it.
Doctor, do you have time for a question?
You have a question.
Yes.
Great. But you can see there's no fusion there. Let me have the osteotome. Yeah, if we drill it, we're going to need a bigger cage. And I don't want to do that. Give me a second on the question. I can't really take a question at this very moment. Because this is such a cluster. Trying to create a plane. Between the implant and the bone. Gosh, what a mess. So definitely didn't fuse, but getting it out is going to be difficult. What? What are you saying?
I'm saying like, pressure on this side is not coming out.
Let me just think for a moment. All right, what's the question from our audience? Let me look at the MRI.
Yes, we have a question from Facebook. How do you feel about steroid and epidural injections?
Well, I think... No, the CT is fine. I think that steroid injections are okay to do if you want to put surgery off for a little while and you don't want to have the surgery done. The steroid injection can give you some temporary relief for maybe a few weeks or a few months. So it's very useful in that sense. However, when it comes to actually fixing the problem, steroids don't fix the problem. I feel like I'm driving a stick-shift car. Huh? What are you saying, Luis? Oh, it's wiggling around. I just trying to get it freed up. I'm trying to think, how could I do this? If I could get something extra in there. What could I put in there? I could put a bigger needle holder. Let me see the needle holder. I might be able to get a coker in there. I don't think I can get a large bite. So, I know the narrow bite, it's awfully close. Okay, let's try both of these.
I'm saying this blade is not pushing down. Do you have another blade?
No. The blade is not pushing down. That's not the problem. Let me have a pituitary. Heavy.
Can I have a pituitary, please? A big one, please?
I think I'm gonna have to drill this sucker out. I think I'm gonna have to drill this thing out. Fuck. Did not want to do that. What a mess this guy created putting this piece of shit in here. A lot of these are, unfortunately, personal injury cases. I don't think this one is, but let me have a drill. Let me have my drill.
So you want the normal drill? Or
No, my normal drill.
normal drill, alright. Ready?
Yeah. I'm going to try to drill a little bit of the interface between the bone and the implant. Where's my drill? I may be able to get a coker in now. Leave the esophagus alone. I may be able to get a coker in there now. There we go. Oh. Now what's holding this in is scar tissue, by the way. Nothing more or less than pure, unadulterated scar tissue. Bipolar. Huh? What? It just makes me so angry that surgeons do this kind of stuff and use this kind of garbage implants. And for what reason? There's really good implants available, coker, that work, that are proven. Why experiment with stuff that, you know, somebody concocted that doesn't work? And to put that on some patient, it sucks. Because this is what has to happen then to fix it. And honestly, if this was a decompressed level without a problem, I just leave the implant in and fuse over it. But the problem is that this is not a decompressed level. All right, Patel, I need your help. Just pull straight out. Okay, hold on. Let me get this clear. Oh, there. Now go ahead and, not too hard, but straight out. I think we made some progress. Maybe a little bit. Woo! Let's try the narrow bite. This is like the Velociraptor. That's not a narrow. Is that a narrow?
Yeah.
I don't think I can. Well, no. Let's get the coker one more time.
Yes, sir.
All right, Patel. I'll do the coker, and you do the other one. Ready? Let's go. Yeah, straight out. Yeah, the problem is the coker is now going through this path of least resistance.
Sir,
Nope.
we use the mallet and try to heat it up. Pum, 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 pum.
And try to what?
Try to hit the mallet reverse. Pum, pum, pum. Trying to get it out.
I'll
with the
try.
mallet.
I'll try. It's not a bad idea. Give me the coker.
Yes, sir. Yeah, that's,
So this is real surgery, folks. This is what happens, you know. It's just you get into these difficult situations. I just can't get enough force. Wait. I don't want to break that. Keep an eye on it, Patel. Is it coming at all? No? Fucking hell. Everybody getting to see this nice and good? Yes or no? Maybe so. Coker?
yes, sir. Ready?
I'm going to try to get... It has wiggled out about 1 millimeter more. I may be able to get... Okay.
You don't want to just destroy like this.
I do want to destroy it, but once you destroy it, you lose the structural integrity of the implant, and you can't use it to leverage yourself to get it out. You can't use it. Now you got to take it out piecemeal. Oh, I guess we don't have much choice at this point. All right, let's I guess let's do that. Hmm?
Yeah,
The half in a meter.
so we use this type of drill and try
Yeah, I
to
know,
weaken it.
I know. The drill is just so destructive. You lose. We're gonna have to use a drill. I just wanted to try to get most of this out first, without the drill.
How about if you put the distractors, pins, and then open the spacer more?
That is a smart idea, Luis. That is why I pay you the big bucks. Let's do it. That's the best idea we've had so far. Let's have a Penfield first. I think I've worked up a little sweat here. Call my gym, tell him I don't need to come in today. Well, get your lipless.
Yes, sir.
I need you to protect the esophagus. Patel, get in there, please. Right here. Right there. Post. At least the bone is going to be sclerotic, so you're right. It should. This should work. Luis, you may have saved the day.
Well, we're gonna see. I mean, I hope.
Very good idea.
I hope so.
And let it be a lesson to the surgeons. Don't just think you have the best ideas. Listen to your team, especially if you have good people. And if you don't, I pray for you. Now it. Looks like that's where they put the original distraction post in. You see that? I just want you to know, this team we have here is not at the hospital. This is an outpatient surgery. We're doing this at Duke Spine Institute Surgery Center, Viera. We're an ambulatory surgery center. We're not part of the hospital. And we are doing this surgery outpatient, basically. So a lot of these surgeries are migrating. Let me have a Penfield. We've been doing ACDFs outpatient now I've been doing them for 10 years. We've had no problems. This is an unusual ACDF because there's a prior fusion and implant which has failed. And so now we're trying to fix someone else's failure. Suck. Alright. Let me have the osteotome. I need you to suck that interface. Let me have the osteotome. You have to be careful doing this because you have a vertebral artery back there, and if you chop through it, it's going to be bad. Of course, the spinal cord is back there as well. All right. Let's have the coker again. All right. Let's bring in the microscope. Fuck. What a
Yeah, so
true
we need to-
disappointment. We're gonna get my headlights and everything off, please.
1 second, yeah, disconnect first and then we do
So at this stage, we've done our exposure of the spine. We're trying to get the failed implant that was put in at C56 by another surgeon 2 years ago or 3 years ago. And it's loose, it's failed to do the fusion, and it's being held in by scar tissue, basically. And of course, we're limited to how much force we can apply and how much leverage we can get on the implant. Let's go, guys. Just get the head thing off, please. Loosen the back, loosen the top, lift it, and take it off. Reach front, grab the speaker, and the little box up front in the front pocket. Grab the knife box out of the back pocket.
Alright, and I have to grab the other headset thing. Go grab that.
Hear me? That's what I figured. All right, put my glasses on. Over the ear. Perfect. That's great. Can you guys hear me?
Yes.
Yeah. That's fine. Behind you. All right. So Patel, you remember how to do this without contaminating your gloves?
Yeah.
Stay away from the perforations. Stay away from the exposed thing. Okay, so we're going to move under the microscope. Now the microscope is a surgical microscope. There's only a few doctors that know how to use these. Okay? Most neurosurgeons do. And pretty much orthopedic surgeons don't. I've never met an orthopedic surgeon that knows how to use the operating microscope. So, all right. There we go. You can see the implant a little better, how loose it is. Suck, please. Drill. I've got to try to get this thing out with the assistance of the microscope. I've already distracted my distraction pins as wide as I can. I need you to suck down here. You need a narrower sucker, that's the problem. Suck, please. Interesting. That's the bone graft that they put in. Unfortunately, it never fused. It just stayed in the middle. That's one side. Let's look at this side here. Again, just scar tissue. No real fusion mass. Don't suck that soft tissue into the wound, please. I just need you to suck the sawdust, Dr. Patel. Can you do that? There's a lot of it. Yeah, get all that. Suck it out, please, so I can see. The pituitary. Help me. I need you to suck, please. Suck, please. I need you to suck, please. Irrigate a little bit. Thanks. Let me see over here. Yep. In and out. Good. Out. That looks like what the hell was that? Somebody's needs a. If that was a stool, someone needs a, what do you call it? Bowel relaxer. All right. So we are drilling at the top surface of the implant. Suck, suck. It's all scar tissue. Question is, can we get it out now? Let's find out. Still scarred down. Look at that. Incredible. Scarred down. Well, this implant did a great job of making scar tissue. What else can I say? The one thing you don't want. Who makes this implant? Zimmer? Zimmer Spine, right? Zimmer Spine makes this implant. And it did a great job of making spinal scar tissue and screwing this patient's life up, making him have another surgery. This is a big ass space. What's your biggest cage? Cage. No, we're gonna need bigger than that. Do you have a fibular allograft? Let me have a coker. The fucking coker. Perfect, huh? So, this is why you don't let most spine surgeons operate. What's all this back here? This is all herniation that was never taken away. Because they get afraid to go back on the spinal cord. They're afraid to be back here. So they don't do surgery back here. Go ahead and save that. Save that. Come on. Be ready, please. Why didn't we save the other stuff, Louis?
Huh?
Why don't we save the other stuff?
I have a
Think carefully. Why?
Why? Because that is scar tissue, you're the one there.
No.
This is a good
What did I drill away before? Dr. Patel. What were the fibers before? What was I drilling away before?
cage.
That's right. Do you want to put the cage back in?
Oh, no.
So what am I removing now? Bone, yeah. I'm removing bone spurs that the other surgeon never took out. Back here. So why would I want to harvest now? Because the cage is out. Once the cage comes out, that's when you give me that tool. Just suck this. Suck, please. This is all herniated disc that was just left here from the last surgery. Please don't let me hit your sucker. How's the view there, Diego?
It looks good.
Those are all bone spurs in the back that were never taken out from the last surgery. Right here, this is a bone spur. They're in all four corners. They were never taken out. All right, now we're at the back of the disc. This is the herniation. It was never taken out. That's why you don't want an orthopedic surgeon doing your spine surgery, okay? They just, in general, curette. Curette number 3. They just don't do the decompression properly. They don't get to the back. And honestly, a lot of neurosurgeons don't either. This is too big. 2. Suck, please. I cannot see. This is where I have to actually see what I'm doing. That's your herniation, folks, right there. Never taken out during the first surgery, just left. This happens all the time. This is why people get bad results with spine surgery, is the surgeons just do shitty, sloppy work. Kerrison 2. Okay. This is a 2 or 3? Wow. Huh? The failure was caused by A, not removing the herniation, B, not using a good implant, a good biomechanical implant that works. Just using some newfangled, I'm going to get a commission for putting this thing in from the implant company. I'm going to get a kickback, even though it's a piece of shit. That's what unfortunately drove. And then lack of good training, maybe, you know. It's probably a combination of things. I don't even know who the surgeon was. I really don't care. The truth is, as you can see right here, there's proof he left the herniation. This is the herniation. He left it in. And that's typical of orthopedic surgeons that try to do ACDFs. You know, orthopedic surgeons are not trained really well to do ACDFs at all. Less than 1% of them, I'd say, can do a good ACDF. So, unfortunately, though, 50% of neurosurgeons suck too at doing ACDFs. So who do you go to? You got to go to somebody who's actually good. And that's hard to find. None of the surgeons are ever going to tell you, whether they're ortho or neuro, oh yeah, I suck at ACDFs, let me do your ACDF. All they think about is how much money they're going to make doing it, and then they do it, even though their results stink. Right, Dr. Patel? That's the spinal cord, by the way, the white thing there, we're going to show you in a minute. That's the foramen that I'm going out right now. That's where the nerve is. Right here. So the white thing is the spinal cord. This is a real decompression. Now, this is the way it's supposed to be done. You get rid of the herniation in the back, which is what you're looking at right now. Okay? That big blob sitting in the middle. I can't get there. All right, pituitary. That is the herniation. Right. You gonna send this off? Oh, it's stuck down now. Yeah, we got a piece of it out. Let me see. It's stuck to the spinal cord. All right, let me have a curette. So I got to create a plane between the spinal cord. Careful on the spinal cord. Thank you. And the back of the bone spur. And actually what runs back here is the posterior ligament. Posterior longitudinal. Suck here. Let me have a curette. Okay, let me see a Kerrison too. Sorry. Take that. So I'm developing a plane between the spinal cord, which is the dura, the covering of the spinal cord, and the back of the herniation, which is the posterior ligament and the bone spur. Because they're scarred together, because they left that herniation there for so long, it just scarred to the dura. Now there's a nice white dura there. You see how clean that is? There's no scar tissue there. Okay? So I'm working my way around the scarred herniation, trying to develop a nice plane and isolate it so I can get it out without hurting the patient's spinal cord. Here we go. Come on, quick wipe. And now I'm coming out the foramen on my side, which is her right side. Any idea which arm bothered her more? No? This is a foramenotomy. We have gel foam. Let me see. It's looking good. Let's go gel foam. The white thing back there, folks, is the spinal cord. That's the covering on the spinal cord called the dura. So you're looking at the dura covering over the spinal cord. Now, you see the inflammation at the back of that? Everyone saw that, right? How the herniated disc was stuck. I need the cage. We need, let's go with a trial, the biggest cage you have. What do you have? Come off the gel foam, please. Come off the gel foam. So everyone saw how the back of the disc herniation was right up against the spinal cord dura and it was stuck to it. That sticking to it is from inflammation. That's what causes the sticking. And people always complain about headaches when they have a herniated disc, right? About 66% of the patients with a cervical disc herniation that's symptomatic causing neck pain, they also have cervicogenic headaches. So basically, well, how wide is that? What, is there a narrower one?
Yes.
I want the narrow tallest. Come on, guys. I always use the narrowest. That doesn't change. It's just the height that changes. Oh my. Is that the skinniest, tallest?
Yep.
Take your time. Don't drop it. Hey, what are you doing over there, Doc? Everything okay?
Checking blood sugar. She has Dexcom monitoring the right arm.
Sure. Come on, guys. Fucking unreal. All right, it's a good time for a question. For those of you wondering, we've put the microscope in. This is a $200,000 surgical microscope specifically for neurosurgeons and neurosurgery. Orthopedic surgeons don't use it. Most neurosurgeons know how to use it. Some don't. If you don't use this microscope for this kind of surgery, you're not going to get the surgery done properly. All right. So let's go ahead and implant this. Suck, please, just gently. Let me get the blood out. See? And this is how tall?
9.
You don't have a 10? Okay, let's pack it. You know, a case like this, you should be prepared with taller cages. Shame on you. And you should have them in the facility. It happens again. I'm going to switch to another company, honestly. Yeah, don't let it happen again. I've told you guys to park your stuff here. Why is it not parked here? I don't care. They have to let you keep it. I thought you keep sets here.
I do have the very minimal sets. I had to get all of this, the cages stay here. I had to get all of the trays for this.
Yeah, but there are taller cages. There are taller cages. Yeah, they should be here, parked here. At least one of each size. Okay? Not, you know, the skinniest ones, which are the ones that I use. That make sense? Okay. Well. Let me have some bone graft. All right. Do you have any more posts, or is that it?
That's it, but we can open another one. We usually, it's longer, but we can open another one if you want.
Who's moved my hand pieces? Huh? Who's moved with the? Who's messed with this?
No, nobody.
Yeah, somebody has. Because this is not where I normally have them. Anybody touch the scope?
Only me, sir. That's what I'm saying. Only me.
Yeah. Fucking hell.
Do you want to post it, sir? Or just want to jump it like a...
Let me have the post remover.
Yes, sir.
Get in there, Patel. I need you to move the esophagus. Come on, man. We need something to hold the esophagus over. We do this every single time. It's a Penfield #1. That's what we use every single time, okay? Don't make me have to do more than I already have to do. It's a difficult enough case. Do what you're supposed to do. Think about the pieces we're supposed to use, Luis. Okay? That's correct, but it's after the Penfield. Pickups. I need your help, man. Okay, we do the same thing every single time. What is the order? Post, Penfield 1, right? Then bone wax, and then pickup. It's the same thing every single time. Suck, please. Suck, suck, suck. Suck. All the juice. Not there. Right where I'm looking, where I'm going to put the post in. Bipolar. This is where the post goes, okay? That's where I'm looking at. Post. You're stirring up the bleeding again. Bovie. I told you got to be careful when you suck. The sucker itself will actually make bleeding happen. Suck, please. Okay, post. This needs to be in the middle. Mallet. Mallet. All right, that looks good. Post distractor. Eyes. 15 blade. Suck, please, here. Suck, suck, suck here. All right, you can see there's partial avulsion of the annulus. This was one of the discs that were damaged as a result of the prior surgery and the bad surgery that was done. Adjacent segment disease. When surgery is done properly, like a fusion, your adjacent segment disease rate goes down to about 1%. But it's much higher in the literature, it's much higher with other surgeons because they don't do the surgery properly. And there's many ways to mess the surgery up. One of them is deformity, not correcting kyphosis or listhesis or scoliosis, and doing a fusion with a spine that the surgeon leaves, scoliotic, kyphotic, or lordotic, and too much deformity will cause the adjacent segments to wear out. Another reason you get adjacent segment disease, besides the surgeon not doing deformity correction during their surgery, is damage to the adjacent disc or joints during their first surgery. A lot of surgeons do that damage. They don't do it on purpose. They do it unintentionally. However, I do know one surgeon who I know for sure has done it on purpose. And I won't mention any names, but they don't work at Duke Spine, obviously. They work somewhere else. But I see a lot of their patients. Let me have a smaller curette. And their patients come in with horrible adjacent segment disease, and they do multiple surgeries, and every time the adjacent segment disease is done because that surgeon puts the screw into the next disc during the surgery. So it pops the disc and makes it wear out over the next year or two, and they come in with more pain, and the surgeon does another surgery. I've seen that happen. That's perfect. I've seen it happen. It's real. There are some very corrupt surgeons, not a lot, thank God, but I've seen it. At first I didn't think it was done intentionally, and then I saw 5 more patients with exactly the same thing. And I heard this surgeon has patients in their waiting room that have had 2, 3, 4 surgeries already done by that surgeon in the same area of the spine. And I realized what was going on. Of course, we reported it, but nothing was ever done. So, a lot of patients are unsuspecting about some of the problems that can happen with spine surgery. That most of the problems, honestly, are driven by the surgeons. For example, I used to do these surgeries at the hospital, and then I realized the hospital was not doing their job, their part for the patient. They didn't have the right equipment. They wouldn't upgrade the equipment. They didn't have the right personnel doing the surgery with me. Correct. They had, for example, they were using nurse anesthetists. Okay, they took all the anesthesiologists out, and they just used nurse anesthetists. And the nurse anesthetists were not doing a very good job with the patients, and the patients were waking up with pneumonia. And they were getting pneumonia after surgery and all kinds of heart problems they didn't have before. And when I investigated, I realized that they were not managing their fluids properly. Can you get that shit out of there, please? So, you know, where the surgery is done is actually important because it's not just the surgeon. There's other people involved in the care of the patient that can really mess up the surgery results. By the way, there's the herniation there. Right there. You see that? I just pulled it out right there. That little wad, that was the herniation. And there's the tear in the back of the disc right there. So this is 4-5. And we can see the herniation and the tear. I'm inside the spinal canal, right above the spinal cord. That's what we're going to go get the rest of the herniation out of there. Curette, let's see curette first, sorry. Let me have a 3 again. I need to scrape some more of this cartilage out of here. And then we're going to drill and try to save some of the bone. Okay, wipe. Oh, you didn't wipe it. You didn't wipe it. Stop wiping where there's junk. Move to a different, cleaner part of the towel. Okay? Otherwise, you're just going to end up putting it back on my curette. Okay, can you get that, Dr. Patel? Are you not able to get that out with the pituitary? Huh? Your sucker is definitely not going to get that out. Drill. I'm going to try to harvest some bone here. This will probably be a 7. The drill is a much safer way to do this in the back of the disc. Now you see what I just did? The surgeon before that did the other level we just got through with, he or she never did this, okay? They never did any of this. They never went to the back of the disc, they never found the herniation and got it out. And you have to also remove some bone spurs in the back. Suck, please. If you don't remove these bone spurs, you're not going to get to all the herniation out. You're not going to get all the decompression done that needs to be done for this type of surgery. Plus, removing the bone spurs actually helps with the fusion because you're decorticating back here. Suck. All right, now we've gotten rid of all the bone spurs. All we're left with is the posterior ligament and the annulus. Curette? Curette. 2. Once I get done with the drilling, it's always a 2. Before the drilling is a 3. There's more herniation right there. Y'all see that? There's like the tail of the herniation coming through the back of the disc. So I'm going to go in here. Oh, yeah. Look at all that herniation there. And there's inflammation, too. People don't appreciate how much kerosene, too. They don't normally appreciate how much of this disease is driven by inflammation. Dr. Patel, you do. Look right there. There's a herniation. You see that? Right through that little space. Patel and I both understand how the role inflammation plays in symptomatic disc herniations. But most surgeons and most doctors don't. They think it's all about compression, pressure. They think it's all the pressure that's being put on the nerves. The pressure on the nerves has nothing to do with the pain in the neck or the head or even the pain down the arm. Pressure on the nerves may have something to do with the weakness and the numbness and the reflex changes, but it has nothing to do with the pain. Pain is from inflammation. That's why most surgeons won't treat herniated discs that are painful. They just say, oh, there's nothing that can be done. Look at all that inflammatory stuff right there, herniation. That's a big herniation. It's a lot bigger than I thought on the MRI. The MRI doesn't even show it that well. It must have gotten worse since her MRI. How old is that MRI? Huh? Suck, please. October? February this year? So what, 4 months ago? 6 months ago. Yeah. Yeah, that's why we like MRIs to be within a year of the surgery date. Unless the symptoms get worse, then we need to do another one. This is herniation here. We're about to take out. You got your sucker clogged. Your sucker's clogged. Careful now, careful. Don't go in there like a cowboy. Don't mean to offend any cowboys, but all guns blazing. All right, just about done. Suck. The foramen is wide open on both sides, so that looks good. That looks really good. We got all the herniation out. Let me see. Yeah, I think this is a 7.
7? Okay.
The last one was a 9 because we had to drill some more. I think this is a 7. Let me see a 7.
I need to pass it, okay?
Go, go.
Alright, I'm gonna leave it over here. There's a couple of
Can you babysit that? I'm going to drill just a little bit. decorticate, even out the surfaces. Any questions from our audience?
Yes, we have one question from YouTube. If a fusion and excuse me, sorry, if a fusion and instrumentation surgery went well in the neck, how much time goes by optional conditions until it is revisited?
I think that's good size right there. Let's pack it up. I'm so sorry. I was focused on the cage and the right height, and I missed the juice of the question.
Okay, yeah, I can repeat it. If a fusion and instrumentation surgery went well in the neck, how much time goes by in optional conditions until it is revisited? And have patients went 20 years with it being okay?
Yeah, if the fusion is done properly, which it's really hard to do properly. What I mean is most surgeons don't do it properly. If the fusion is done properly, it lasts a lifetime. You never have to worry about it again. And honestly, in my experience, 1% of those patients that have perfect fusions, 1%, 1 in 100 get adjacent segment disease. And it really doesn't have anything to do with anything the surgeon does. The surgeon does a really good job, but they still get adjacent segment disease. So they still have a disc above or below that wears out.
You don't want it to impact a little bit more?
And I will,
Okay.
once I get the post out.
Gotcha.
So good fusion lasts a lifetime. It never has a problem. I have patients I did 20 years ago, fusion, and they have no problem. I mean, most of my patients, probably 95% of them. Now you can start getting some pain in other areas. Remember, a fusion only fuses one motion segment. I need pickup, please, like I said before. It's always a pickup. A fusion only treats one motion segment. And if you have two levels fused, then it's two motion segments. But basically, a motion segment is the two bones above and below a disc and the disc itself. All right? So you can get pain not from the fusion area, but from an area above or below the fusion area, or a muscle nearby, or a joint nearby. So it's common for people who've had fusions to get aches and pains from other areas, but not from the fusion area if the fusion is done well. All right, let's see what we got here. Suck that, please. Suck that hole. Yep, suck the hole. No, this hole right there. The hole in the bone right there that I just took the post out. That's not the hole. Yes, that's the hole. Yeah, I want to get all the soft tissue away from the hole so the bone wax goes in. And it didn't. That was my fault. See what I mean? If you have a lot of slippery junk around the hole opening, and the bone wax won't go in. All right, so those holes are closed. I want to bring this in a little further with a mallet.
You don't need to pick up dispenser?
I think that's good. It's flush. And this one I can put in a little more. Let's come south a little. Let me have a Penfield. Hold on. That's the esophagus. We want to move it out of the way. I could probably countersink that a little bit more. Let me have a impactor. Mallet. That's pretty good. And now we're going to do the last level at the bottom, which is going to be tough to get to, but we're going to use handhelds first, and we're going to re-put the self-retainers after we're done, exposing it with the handhelds. Okay, I need patels first, always, always, always. I place patels. All right. So that's the esophagus right there. Okay, that's the outer wall of the esophagus. All right, Patel, get in there and hold that. I'm going to move the eye pieces. Eyes. Yep. All right, there's a little vein there, bipolar. Don't suck it. No, I wanted it. I was going to bipolar it. Why did you do that? Ugh. Irrigation, suction. Take. Let me have your hands. Let me have this. Right here. Hold it in the corner, just like that. Can you do that?
Yes.
Suction.
Suction.
I need suction from Patel. Fuck. You're kidding me. Unbelievable. Alright, there's the bone. I gotta get the bovie. I gotta open that a little more, Patel. You ready? Don't let me hit anything. Okay, now your side. Here. Yep. Hold this, Luis. Let me have the Penfield.
Yes, sir.
Hold it right there. Yep, that's good. Great, guys. You're doing great. Hold it for just a minute for me while I get in here and give us a little more exposure down south. All right, that should be good. Let's have the post. Oh, actually, we need self-retaining first. Take that. Yep. Let me just look here at this. Suck here, please, Dr. Patel. You're my suction. I can't do it without you. Yeah. Let's have the bovie one more time.
Yes, sir.
I want to clean this up on the edge. Supposed to suck the smoke.
That's okay.
Okay. Let me actually do mine first.
Yes, sir.
And this is the 45?
That's a 45.
Uh-huh. Take that. All right, Patel, I'm going to come for your side. I'm going to need to... I'll try to slip in on the north end. Okay, start moving out. Yep, keep going. All right, hold it right there. Hold it there. And let me have a Penfield. I'm going to sweep the esophagus around your bottom corner. Stay there. Don't move. Yep, that's great. Now you're free. Now, go ahead and get a good hold on that. You have to have it facing me. You're angled south. Otherwise, these won't lock in. Yeah, thanks, Luis. Good job. That's the problem is the tissue, the soft tissue is there. Are you in, Patel?
Yeah.
Are you engaged? Engage with this. Go ahead. Push it towards me a little bit. Push this towards me a little bit and make sure it's engaged. All right, that's good. So hold on. Hold on. All right, now come out. Not so hard. You know, come out gently. Wiggle and up. All right. No. Don't suck the esophagus. Penfield 1. Penfield 1. I'm gonna need the her soft tissues are really, her clavicle is starting to affect us down here. Let me have a narrow.
Yes, sir.
Patel, I need you to hold the narrow. Come on, I need the narrow. I need the narrow means I need the narrow, not Patel. I'm going to give it to Patel, but you don't give it to Patel. I have to place it first. Now suction. All right, let's go with the post. So that's the C7 bone right there. Your hand has got to let me come in properly. Yep, that's right. I already know that guy's in bad shape because he's broken at the bottom there. Let me have a post. This was the bone from the failed fusion. I'm not going to be able to destruct that. I don't want to destruct the cage. It's a little osteophyte fracture there. Let's have a drill. Take that. I don't know that I could use the post. All right, Patel. I'm going to drill some of this away. Just don't move, okay? Oh. That was good. That was good, actually. 15 blade. So, what's interesting is this appears to be something that was a result of perhaps the prior surgery somehow, which makes no sense to me. I think I just woke it up, so to speak. Because that's on that bone from before. Go ahead. It's very scarred, very inflamed disc. Huh? 15 blade again. You're not going to get any of that up, so I got to cut it out more for you. This hand is really affecting me. Go ahead and move it. Try again. So when they did the first surgery, they actually fractured the bone there. When that other surgeon put the post here to open this disc up, he opened it and cracked through the bottom, and then that's why we found that fracture. It's an old fracture, you can see. It's organized. Basically, we have a fracture of C6, old, from prior surgery. Just document it. Just from prior surgery, distraction post. What a mess. Just mess after mess after mess. This is why surgeons don't like doing these cases, by the way. They come in here and they find all these difficult issues to deal with that are honestly very challenging. I'm just too stupid to say no. I just hate knowing that I can help somebody and let them go out and suffer. Careful over there. Never grab where you can't see. That's one of the golden rules of surgery. Go ahead. Let me have a kerosene.
4. Yep.
Wipe. Any questions from our audience?
No questions, but a lot of praise.
No questions, what?
No questions, but a lot of praise by our viewers, saying that you're doing a good job.
Oh, thanks. I appreciate that, actually. That gives me encouragement. Thank you for the praise and thumbs up and hearts and all that good stuff. I like it. So basically, we're at the bottom disc now, the one that was below the old surgery. And this one blew out as well. And there's a herniation. Not as bad as the one up higher. No, I think actually, no, this is the one that's worse on the MRI. So, yeah, I guess we will see something. But we're just scraping all the disc away. This is all the nucleus pulposus. This is the jelly that's in the center. People wonder what the jelly looks like. This is it. It's really not watery. It's more firm. And the reason it's jelly-like is that it's got a lot of water content. It's made out of high hyaluronic acid primarily, which is a carbohydrate. It's got like a long carbohydrate chain, I believe, and it just binds water. And our bodies use hyaluronic acid in places they want a gelatinous substance to act as a cushion, right, Dr. Patel? That's why discs are 75% water, because of the hyaluronic acid. Like the brain, for example, doesn't have any hyaluronic acid. It's all fat, made out of myelin, fat and electrolytes and neurons, supportive cells, the glia. But the point is, there's no watery substances in the brain. The brain is very fatty. All right. So really hard to get down here, but we made it. Let's see what we got. This whole bone has been compromised from the prior surgery. So we're gonna get this herniation out, and then do we need bone?
Yep.
So that's a bone spurs that I was drilling. And believe it or not, bone spurs are actually pretty good. Not as good as real bone marrow, but pretty close. Eyes. Drill. Drill. Can you imagine doing this without the microscope? It would be working in a dark area. You couldn't see anything. The microscope helps a lot. That's why I don't do this kind of surgery without the microscope. Even after doing 1,000 of these surgeries with over 2,000 discs, I don't do it without the microscope. Because, and a lot of surgeons do it without the microscope, and they honestly don't have half the skill I have and experience I have. And I would never do this surgery without the microscope, never. Because the microscope is necessary to see what the hell you're doing. Otherwise, you can't see anything down here without the light and the magnification of the microscope. And yet a lot of surgeons do ACDF without the microscope because they don't have it, and they don't know how to use it even if the hospital were to have it. This will be a 6. Show me. Show me. Yeah, this will be a 6. This is the hardest disc to get to, this C67. Actually, there's one more, C7T1, even further down, that's even harder. Thank God there's rarely a problem there. But point is, if my staff called me today and said the microscope's broken, I would 100% cancel this case. I wouldn't even try to do it without the microscope. That's how important the microscope is. Yet, and I'm a very well-trained neurosurgeon, like really well-trained, and I don't want to do this surgery without a microscope. That show, I mean, how could there be surgeons that do the surgery without a microscope? Yet, probably 70% of them do this type of surgery without a microscope. They don't get the results. That's why there's so many people with problems after spine surgery, because it wasn't done right the first time. So, you want to do this surgery right, you got to have a microscope, in my opinion.
We have a question about the microscope.
Yeah.
What magnification is the microscope?
Ooh. What magnification is the microscope? I don't know. Maybe it's a 2.5?
Well, this one is 4.5.
Oh, 4.5. Sorry, 4.5. 4.5. 4.5 times. But it's not just the magnification, it's also the illumination. Turn the light off for a second. Let people see what it looks like without the light. There is no light other than the microscope that can look at that. Okay? Can you imagine working in that dark hole? I mean, honestly, the microscope isn't just about magnification, it's also about illumination. Illumination and magnification. So light and, magnification. All right, almost done. That's the spinal cord down there. I'm going to test the 6. Don't pack it until I test it.
Yes, sir. Yes, sir.
That's herniation right there in the foramen. Oh, yeah, careful. It's like scarred up posterior ligament. We're going to use the narrow again like we always do, okay? Let me see your side patella. Ooh, see the dura just buckling right there? I don't want to do any damage to the dura. If you damage the dura, you're going to get a spinal fluid leak. You don't want a spinal fluid leak. That's good. I think we're a 6, guys. I really do. Let's try a 6 and just size it up and see if it works. Before I do that, I want to try a 6. I think we're okay. Let's put one of them, I guess. This is gel foam soaked in thrombin. It does nothing but other than stopping the bleeding. And there's really not much bleeding, so. Thank you, Luis. 6 looks good to me. I think it's a 6. Did you pack it or no? Okay, go ahead. Yeah. No, we're good. I put some in. All right, so at this point, we've done the decompressive discectomy at the top, which is C45. We did it at the, we took the implant out. We explanted the implant, which was a failed fusion attempt and a failed cage. And it generated a lot of cursing in the beginning of the surgery. And then now we're doing the disc below her prior fusion, which is C67. So we've done all the discectomies and discectomies so far. And now I have to put this last cage in, and then we'll be done with the discectomy and the cage and the fusion part. And now the last thing to do is our metal plate. Can you pull back on this? Toe? Yeah. Gonna get this post out. So I need bone, wax, and then a pickup. Suck, please. Got to plug the hole in the C7 vertebral body. You got to get that soft tissue out of my way. I would pull it towards you. That's good. Oh, you had it for a second. Good try. Let me have that. Let me have that. Let me have that. Let me see. Let me get in. Are you still on there? You got to bring this back, dude. What are you doing? Toe. Yeah, there you go. Now suck. God damn it. You gotta make sure your sucker is always open. I need to see you move your finger back. I cannot see, not too much. Everything up here is blocking me.
There you go.
Okay, done. Relax. Come out. Wow, what a difference between this and the Deuk Laser Disc Repair, huh? This is like a massacre compared to endoscopic surgery. That's why endoscopic surgery is literally going to replace all these surgeries. I need you sucking. While I'm talking, you should be sucking all that blood out. Okay, so I can see what I'm doing. Because I can't do the next thing until we... Alright, that looks good. That's the esophagus right there. Let me have the pen field. All right, any questions from our audience? We're going to start the last stage of the surgery. Pen field. Where's my pen field? I put it here. I want it. This is just delaying.
There is no
Alrighty,
questions.
long case. Huh?
There is no
Don't
questions.
suck that over here. Fuck. This. Can you help me here, Dr. Patel? Come on. Are you watching, Dr. Patel? What do you think you need to do right now? Thank you. All right. I can't see down there. We have to see that bone. Right? If we can't see C7, we can't put a plate in. Can we? What's bleeding? The hole. All right, bone wax. Lipless. This is just dragging out, guys. This is a waste of time. We've got to move and be more efficient with our time. Hold this here. You see how nice? Look at that. Move your hand. Look at the view I'm giving you. Now suck the hole. Look at that. Okay? Can you do that? Now notice, watch. I don't have my hand here like this. Can you see the hole? Okay, I'm way back here on the retractor so that it allows the surgeon to see right past. Millimeters matter. Let me see. There we go. All right, much better, much better. Let's get our plate. What size plate are we going to use? Yeah, whatever Amy says. That's what we try. I need a retractor for the top. All right, we need to go to the top, Dr. Patel. I need a here, take this plate. I need a retractor for the top. What a fucking clusterfuck. Come on, Bada. We're going to be here all day if we don't get the little details done right. Okay, this retractor cannot move. It has to stay there. Let me do that. You hold this retractor in place. Hold the retractor in place. Okay. You said this is a 48? Okay. Okay. All right. Bada. Look how the blades are scissoring here, okay? That cannot happen. They have to stay parallel to each other. Otherwise, I can't get the plate in. Now we got to make sure the plate fits. That's good. There. Now you see how your blade is blocking it right here? I can't have that. I got to have you move your blade over or lift it up a little bit to get the plate underneath it. All right. This looks pretty good. Let's see the top. Yeah, I think this will work.
That works?
Yep. All right. Look at that. Look how the plate is. Look at your retractor is blocking the plate. You've got to lift that edge up of the plate of your retractor to let the plate go in. Okay. I know it's hard. Nothing in surgery is easy. Except fucking up is easy.
Someone asked, what is the plate made out of?
Titanium. It's a titanium plate. Yes, nice job. Eyes. Fucking thing. Bone is extremely sclerotic, but that's good. Got our first anchor point. Now we just gotta get the rest of the plate lined up properly, which should be a little bit easier. Handheld. Come on, handheld. This handheld is what we always use. Dr. Patel, you're letting your blades slide again. All right. Maybe there. Let's get this sucked. Right there. Like this, Bharat. Why is it so hard? Leverage the plate. Leverage the retractor, I mean. All right. Let's see what we've got top and bottom. Let's look at the top first. Top. Let go. Now you don't know how to maneuver this. Not happy with that. Handhelds. Come on in, Dr. Patel. Right here. Okay. Let's look at the bottom. Bottom. Interesting. I think our plate is too long. Move your hand. Move. See the difference here? I'm toeing in. You got to toe in. If you don't toe in, you can't do the retraction properly. Let's get a shorter plate.
Yes, sir.
I need the locking mechanism remover. The fuck is this? This is not it. What are you giving me? Don't lean over the table. Come on. Sometime this century, guys. Your retractor is pushing against me. I cannot seat this properly. How come we got the plate wrong? Normally you're right on. Why did you choose a 48 instead of a 46er?
Because the first space was larger than the gauge.
No. No, it was larger because we had to drill into the bone. The disc space is still standard, 7 millimeters. Nor, give me a handheld, please. Louise, come on.
Ready?
You know, when I take the plate and go in, I'm going to need a handheld. You know that, right? That's much better. This may even be too long too. I don't know. Right now, I think we're going to be okay. This is where our first anchor point needs to be. Drill. Come on, give it to me so I can use it. Let's see what this does for us. That's it. Good. That's good. Let's look down low. Show me low. That's good. All right. So let me go ahead and put one on your side. And we're going to have to get past this soft tissue. Watch that doesn't go through. I need a pen field to sweep this out. Really don't want the longest colon muscle there if we can avoid it. It's not going to help us. There you go. Let me have the screwdriver now.
Yes, sir.
No, the screw fucking driver, not a screw.
You want to do that?
Yeah, I got to put the screw in. That's what we're trying to do, not add another screw. Did you see me drill another hole?
No, I thought you done with that.
That's all right. I need to think for me. I can't think for all of you guys. I need you guys to think for yourselves. You know what I mean? Let's go south. Come south. Come on, we gotta look here, right here, right here. I need you to toe in. Yep. Take this. Nope, I don't need that. I need to see south and make sure we're not pinching the esophagus, okay? I need Patel to show me everything he can toeing in and sucking. Yeah. All right. Yeah, give me the drill. All right, Patel, I'm going to put a screw on my side. I cannot see. Show me here. Suck, suck. Come on. Move. Screw. Okay, that's a good start. Let's take a look at what we've got so far. Yep, let's go north and see what we have left. Okay, that looks pretty good. Drill. We are almost done. We have about 15 minutes, 20 minutes, doctor. So if you want to start waking her up. I need my handheld. Nice job. Come on, hand it to me properly. That's it, Luis. Good job. It's all right, doctor. You're allowed to take phone calls. Suck, please. All right, I want to get these all the way down on the bone. We're going to irrigate and get hemostasis. We'll get a quick X-ray. Let's see here, Patel. Come on, follow me down. Do you see what I'm doing? You got to follow me. You can't daydream. I'm thinking about not putting a screw there. Let's see what we got here. Suck the holes. Suck the holes. Yep, right there. I want to see if there's good bone. Yeah, I think we're good there. And I think we're good there. So yeah, I guess I'll put 2 more screws. Come on. Mm-hmm. At least 1 more. That's a pretty good screw hole right there. Looks good and corticated. This is one of those sclerotic bones. Sclerotic because it never fused. Suck that hole, please, and let me see what you got in there. You know, I honestly don't think we need another one. I don't think we need one there. We left a screw out of the C6. Patient's left. Let me have the screwdriver. I need to tighten this down. So if I ask for a screwdriver, it's just screwdriver, no screw, okay? Oh yeah, see that? That felt good. That felt good. Nice and snug. Nice. Nice. Yeah, we already got those guys. All right, let's get an X-ray, and we'll irrigate. Let me irrigate. Stay in there. Stay in there. No, we put the irrigation. Where's the betadine? Yeah, let me have some betadine. Patel, come out, please. Yeah, normally we put some irrigation and do the X-ray. This way, while we're waiting, it gets to do its work. That's good. No, no, don't suck it out. What are the two things that determine the effect of an antibiotic treatment? The strength of the antibiotic, sensitivity of the organism basically, and the duration that it's left. Sensitivity and duration.
I can do that.
Let's just get a shot, please, and see where we are. All right, so do you need the table up, down, or is it good? It looks pretty good, right? Go ahead. Shot. We're not going to get a good shot because of the shoulders. All right, let me look. Coming in, coming in, coming in. It looks good. Looks really good there. All right, we'll just get some good, better pictures afterwards. Are you doing stimulation, motor? All right, fluoro out, table down. Okay, so you know we'll be closed in 15 minutes, hopefully. All right. You guys ready? What? What? Sure. Hold this here. Hold this. Irrigation. Well, I don't think it has anything to do with what I did. Suck, 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 suck. Good. All right. So at this point, we're going to get hemostasis, and then we're going to close. Let's keep our blood pressure systolic below 110. Okay, doctor? Yeah, whatever you're comfortable with, as long as it doesn't go above 110. All right. And you're going to have the, you have that Avatine, or not Avatine, but what are we using, the gel foam? Okay, good. Thank you. All right. So we'll start on my side, buttock. Look at all the scar tissue. All this is totally abnormal. For those of you who watched my ACDS before, you don't see all this white stuff. This is all from the prior fusion that didn't work. But you see what the point is, it's so traumatic to the body that it causes all this reaction of the body to the trauma and damage of the initial surgery, which is clearly visible on the surface. This surface right here should be smooth and white, but it's not. This is all scar tissue. And the other thing is scar tissue will bleed too. So you got to make sure you coagulate it. Okay. This is more normal. See that? That here does not look like that. This is what the area that was not operated on before. It was above. Let's see the corner. Vada, I need to see the corner. Yep. Right here. Right here. Suck for me. Yep. You want to coagulate this ALL. Show me the corner. You want to go to the corner right here, because that's where there's a little vein and it can bleed. Show me here. Yep. Okay, very good. Dr. Patel, nice job. Look at all the scar tissue there. All right, let's keep going. This is just scar tissue on the surface of the longus colli. It's not doing anything right now bad to the patient. We're not taking it out. And it's impossible to get it all out. So even if your goal was to get it all out for some crazy reason, which won't help the patient, you can't do it because you'll never get it all out. And the more you dig around and try to take it out, the more scar tissue you'll make for this surgery's healing. And all of this could have been avoided had she had a Deuk Laser Disc Repair, endoscopic surgery. No metal, no fusion, just repair her original herniation. And she wouldn't have needed a revision surgery because she would not have adjacent segment disease. Because we don't do fusion or we don't put metal in. I need to get in here. Your knuckles are really blocking me. I need to see. This is where the bleeding is coming from. I need to get access to this area. I need suction. I need to get in here like this, so you got to come in at a different angle. And again, it's the scar tissue bleeding. Wipe tips. Me, wipe my tips. They're getting clogged up with blood cake. Come on, wipe tips. What's this? Carotid artery. Look at all the scar tissue right on top of the carotid artery. All right, good. I don't know. That's good. Let's get our gel foam in here, soaked in Depo. Okay, don't move, please. I'm trying to get this little vein right here while I'm waiting. Okay, good. Looks dry. Come on. Thank you so much. It's a little gel foam for hemostasis soaked in Depomedrol to relieve the postoperative swallowing trouble from all this yorking and torquing. It's a little topical steroid. It's brilliant and it works wonders. All right, come on out. I don't see any more bleeding anywhere, do you? Dr. Patel, thank you so much. You're welcome to take off if you'd like. No, thank you. Thank you so much. Couldn't have done it without you. So I mentioned the microscope. If I don't have a microscope, I won't do the surgery. If I don't have a good assistant, I won't do the surgery either. It's just that important. If you don't have an assistant for this type of surgery, you're going to end up hurting the patient. You want to go to the other side? Oh, you know how to touch these eyepieces? Right here, you never touch around here, you touch back here.
Oh, yeah.
You're going to go to the other side? Move out of the way. So we're closing now, and this right here, in case you're wondering, is the omohyoid muscle. So we're able to preserve it. Showed you a bunch of other stuff. All right, stitch. So now I'm going to close the platysma. I need to pick it up first. Come on. Thank you. I need to find it. Platysma is not easy to find. It's under the fat here. This is it. And the reason you want to close the platysma, if you don't close it, the patient will have a kind of an ugly scar because there'll be too much tension on the skin. The platysma muscle closure helps prevent that by absorbing some of the tension of the wound. See, all these soft tissues, they're going to swell. My hands are a little dry. Can you wet me? While you're doing this, you want to be careful not to puncture a vein. If you do, you got to coagulate it. So I'm watching every one of these carefully to make sure I don't puncture a vein. Puncturing a vein right, it's the tying hand. Okay, just give me a stitch, that's good. And the reason you close the platysma is that it has a fascia. Fascia means a well-organized tissue layer. Everything else is fat, and it's just going to pull apart. So you have to get the fascia. If you don't get the fascia of the platysma, you don't have good strength of this closure. The other reason you close the platysma is it's a barrier to infection. And honestly, The microscope's very helpful in seeing it. If I didn't have the microscope, I don't think I could see it, because it looks a lot like the fat, but it's a little bit pinker. Muscle's pinker. Come on. If you try sewing fat, fat will just pull out.
Doctor, we have a question about plate size.
About what?
Plate size.
Plate size.
Yes.
All right.
If the plate, well, yes. So what determines the best plate size and fit?
Yeah, it's a great question. Really, really intuitive. So the key is to have the holes at the top and bottom of the plate line up with just above or below the end plate of the vertebral body you're putting it in. So those holes should literally hug that end plate. You don't want the holes to be in the middle of the vertebral body at the ends. You want it to be just barely into the vertebral body. And the reason is a lot of these settle. And as they settle, they'll sink. And you want to make sure it doesn't sink too much. Otherwise, if it sinks too much, then you get a deformity. And the top of the plate will go into the disc space above or sink down to the disc space below. Scissor. If the top of the plate starts rubbing on the next level of disc space, you're going to get adjacent segment disease. So that goes along with proper surgical technique to prevent adjacent segment disease. I can't tell you how many people come and they've had a fusion and the plate is rubbing on the next disc above or below. I like to close this layer. Everybody does this different. I have the wrong pickups. I need Adsons. I like to close this layer with a interrupted suture. Some people use running. Pretty much everybody else uses running. I think running's fine. But the problem with running is if you mess up one of them, you got to start all over again. And the truth is, I'm not perfect at it, but if I make a mistake, I don't want to have to start over again. I'd rather just fix the one and not have to do all of them over. But for those of the people who don't mind doing the running suture, it's fine.
We have a question from Facebook. How long is the incision?
The incision is about 5 or 6 inches. 5 or 6 inches, probably about 6 inches. Oh, my fingers are just sticking again. Do we have new gloves? No. These aren't biogels, are they? Are they biogels?
Yeah. You want some irrigation?
Yeah. By the way, these are inverted. And I use the microscope to do it. Pretty cool. The microscope allows you to see things better. One of the only people that probably close these wounds with the microscope, but my feeling is, hey, if you got it, you might as well use it. Oh, this is so sticky here, Luis. Come on, help me out here. Stitch.
Sir, I have a quick question. So,
Mm-hmm.
put some Steroid strips on top of that, and then
Yeah.
do you want some alpha on top of that? Some triple antibiotics, or what will you want? I just want
Steri strips
Steroid strips and the 3 months, and then you want
and a bandage. Yeah.
No.
No. No Telfa, no
Excellent. Just the bandage.
no antibiotics.
Yeah, yeah, yeah. Thank you very much. Thank you. Yeah, no, excellent.
And these are inverted stitches, meaning that the knot will go and bury itself into the fat underneath.
So, Jeremy, do me a favor. We're not gonna use anything of that. Okay. So you can actually start like picking on that stuff. Can we? Do you mind if we turn on the lights?
Yeah, turn them on.
Turn on the lights and then we start picking on.
I've got about 5 more stitches
Thank you.
and we'll be done.
Nope. The other one, the room one, the room one. Yes. Thank you very much. Excellent. Yeah, yeah. That's fine. We're not gonna use anything else. Yes, please.
So Luis, remember when you're doing the steri strips
Yes, sir.
to pull the skin edges close together?
Yes, sir. Perfect. Thank you very much.
So they kind of cover the suture.
Yes, sir. Yes, sir.
That one may not be. I think one more after this.
EMG's clear, transport is water floor, put in the CPs bilaterally, and I did get that motor came back on that left side. I did a small and changed the train from 7 to 11. And I had
Thanks.
good motors on all the way.
Yeah, you see it?
Thanks. Where's the pressure? Blood pressure? Yeah, it's over 110 and we're getting a little bit of bleeding, but it's okay. You gotta bring her back anyway. Wipe. Last one. All right, if you have questions, feel free to type them up. I'll come answer them for you in our broadcast room. Other than that, I think our next surgery is a laser. Is the next one? Is the next one a 2-level thoracic, 2-level lumbar, or a 1? Okay, and then the one after that is. Got it. The big one. That's fine. So, doctor, you able to do this, or you want me to do it? Right on the knot, okay? But don't cut the knot out.
No.
You know how to do it? Yeah. And slide it down. Something happened there. Oh, those are too long. Those are too long. Yeah, you can't do that. Not with these. Okay, you can do that with other layers, but not with a sub-Q. Okay, a sub-Q, you have to literally be on the knot so that the wires disappear. Otherwise, they're going to stick out of the skin. See the difference? Mm-hmm. You don't know where what went? All right, and you'll bring the little skin edges together?
Yes, sir. I got it.
Good job, Luis. Great job. Can I get the scope out?
Yes, sir.
And when you peel that eye band off, do not pull on the skin edges. It'll rip it right open. You understand? Let me show you what I like to do. Scissor. So watch this. I get the edge like that, and I put this here, and I just do that, just gently. So that lifts the eye band off the skin, and then you cut the eye band. You have a nice place to work, okay? Thanks, everybody. Great work. Go ahead and write up your questions for me. Let's get x-rays in recovery, not the OR, okay? Recovery room. I don't want to hold up the turnover. No complications. EBL, I'm going to call 10 mil. And this is a, I'll type up what it is. All right. Yeah, but it's a exploration and revision at 5/6 and removal of this inner body cage. Okay, went well. For the patient standpoint, it went well. It was challenging at times, but we got it done. Team did a great job. Team did a great job. I'll be right there, okay? So let's get questions typed.
The pain level got to about an 8, a 9.
The right side of my body from the waist down was pretty much useless and in pain constantly.
The pain was chronic.
It was an aching, stabbing.
It became unbearable. It became where I didn't want to get out of bed. I didn't want to talk to anybody. I didn't want to do anything.
I had the pain every single day in my low back.
It's torturous. I can't go to sleep at night. I can't lay down. I can't sit for too long. Can't stand for too long.
I couldn't sit. I couldn't stand. I couldn't walk more than 50 feet.
It's excruciating.
Sends excruciating pain across my back. Gets down to my hands where my hands are numb.
I had no life.
If you are suffering from neck or back pain, the Deuk Spine Institute can give you the relief you need to live your life without pain.
Now I have absolutely no pain.
Not even 24 hours after the surgery was complete, I was able to be how I felt is normal. And it was good.
No scars, didn't hurt at all. As you know, when I woke up, it was totally painless.
The next morning, I was up and about and out, dressed on the job.
I have no pain. I'm living my life and doing great things, and I'm just very happy.
It's a great feeling not to be in pain.
Deuk Spine Institute has changed thousands of lives. Isn't it time you live your life pain-free? Log in to DeukSpine.com or call 1-800-FIX-MY-BACK for a free MRI review and consultation.
I feel like a new man again.
And it's thanks to Dr. Deuk. He gave me my life back.
Dr. Deuk did an amazing job fixing my back. I recommend him highly to anybody who has any kind of back issues, any kind of back pain. Don't wait. Go see him. The relief is amazing.
The pain level got to about an 8, a 9.
The right side of my body from the waist down was pretty much useless and in pain constantly.
The pain was chronic.
It was an aching, stabbing.
It became unbearable. It became where I didn't want to get out of bed. I didn't want to talk to anybody. I didn't want to do anything.
I had the pain every single day in my low back.
It's torturous. I can't go to sleep at night. I can't lay down. I can't sit for too long. Can't stand for too long.
I couldn't sit. I couldn't stand. I couldn't walk more than 50 feet.
It's excruciating.
Sends excruciating pain across my back. Gets down to my hands where my hands are numb.
I had no life.
If you are suffering from neck or back pain, the Deuk Spine Institute can give you the relief you need to live your life without pain.
Now I have absolutely no pain.
Not even 24 hours after the surgery was complete, I was able to be how I felt is normal.
Feeling good? All right. You are ready.
I need a countdown.
3, 2, 1.
All right. Hi there, everyone. This is Dr. Deuk Laser. And we have just wrapped up a very complex cervical spine surgery on a patient who had a prior fusion done elsewhere. And that fusion didn't work out. It didn't fuse. Number one, the bones never fused together. And so what's happening in a fusion, just so we can understand? We're taking a motion segment, which is the vertebrae, and the disc between it. Nobody talks about the facet joints and the spinous processes back here, but they're also part of that motion segment. We're taking that motion segment that normally moves. It's got about 3 degrees of rotation and about 5 degrees of flexion extension. We're taking, that's a normal motion segment. We're taking it and we're cleaning out the entire disc. So this is an interbody, that's the body. Inner body is in between bodies. Inner body is the disc. We take the whole disc out. We pack a cage and bone graft in there, and we try to get these bones to fuse together and make one solid bone. That's what her prior surgeon did at C5, C6, except he never took the whole disc out. He only took about half of it, maybe 3/4 of it out. And then when he put the cage in, he used a type of cage, an implant that doesn't work. It doesn't hold the bones immobile so that they can fuse together. So there was no fusion. It never fused. And that was 3 years ago, the surgery. So it should have fused within 6 months to a year. Never happened. So failed fusion, number one, with painful movement, with a terrible implant that was very difficult to get out. And then, of course, the herniation in the back was still there with inflammation causing neck pain and headaches and arm symptoms. So on top of that, this fusion collapsed here because it never fused. The disc above and the disc below, they were herniated as well, and we went in and fixed both of those and the area that was fused. So very challenging, difficult surgery, and in the end, it all went really well. We used an anterior plate. That's the best way to fuse something in the cervical spine. All these companies have come out with all these newfangled fusion devices, and they suck, all right? They don't work. They just make money for people, and they put the patient at risk of having complications. They make the patient's surgery not work, and I hate them, to be honest with you. Why? Because in medicine, we should always do things that are better for patients, not worse. And we should make decisions that are driven by better results, not more money. And the fact of the matter is, these implants, these crazy devices that come onto the market, yeah, they're FDA approved. However, they just don't work. And a lot of these things don't work. So I don't like seeing doctors do things that don't work on their patients. So when I have to clean up someone's mess because they did something that didn't work, it's aggravating for me. It's risky for the patient. She has to go through a second surgery. And, you know, it was hard to get that implant out. If you don't know what I'm talking about, rewind the video about an hour and a half and you see us trying to pull this piece of plastic out of her spine. That's risky. You know, if we pull hard, we could injure the carotid artery, the esophagus. Things can go wrong. So I'm a big believer in neurosurgery, especially when it comes to surgery on a patient. You should do it right the first time. You know, honestly, I hate to say this, people criticize my foul language, but don't fuck around with somebody's, you know, health and well-being as a surgeon. Do what's right the first time. Do the best the first time so you don't have to come back and do it over again. My dad said that to me as a kid growing up. Whatever you do, do it. Do your best the first time. Do it right the first time so you don't have to come back and do it again. And when I didn't do things right, and not because I didn't want to, I made a mistake, I didn't just pay attention, didn't follow directions, I was stupid during doing it, and I had a bad outcome, Dad would come in and say, do it again, make me do it again, all right? So that lesson, that philosophy has been ingrained in my life and in my work. So when it comes to spine surgery, I don't do implants or procedures that don't work well. Artificial discs don't work well. They pop out, they fail, patients still have pain afterwards. I don't do them. I don't do them anymore. I did them 20 years ago when they first came to the United States at University of Florida. We were one of the first universities putting them in. Cervical, lumbar, they don't work well at all, so I don't do them. Okay, stuff like today's implant, it's garbage. It's got no real fixation, and in my opinion, it's destined to fail. So why put it in the first place? You're just dooming the patient to another surgery. It makes me angry because I got to come in and clean the mess up, and I honestly don't care to do that. but I do it for the patients because I want them to get better. But it makes my day miserable. So that surgeon's selfish act has created a lot of problems for the patient, having to have a second surgery and have more discs fused, but it's also ruined my day, and for no good reason, okay? So everything in the end went fine. We got the plate in. I was happy with the result. I think the patient will do very well. You know, what kind of things can you do that lower your chance of a good fusion? Number one is probably some type of an activity that will prevent the bones from being stable and not moving. So some type of contact sport where you're banging your head, your neck, like football, rugby, powerlifting. I've had patients who've had fusions and they went out and they did things they're not supposed to do. And of course, the bones may not fuse as a result of those activities. The second thing you can do is smoking. Any kind of nicotine product, whether it's vaping, nicotine gum, cigarettes, whatever. That nicotine gets inside your body and basically it narrows the arteries really tight so you don't get very good circulation down by where you need it, where the fusion is occurring. You need good circulation. So nicotine products, stay away from them. Overly aggressive physical exercises and contact sports, stay away from that for about 6 months while your fusion is healing. The other thing you can do that's going to make your fusion not work is don't use your brace. So we give all of our patients that have fusions a neck brace or a back brace, depending on what part of their spine is being fused. Wear your brace. That, you know, reduces the amount of movement going on. Sure, it's going to cause your muscles to ache, but it keeps the spine stable and immobile so that the fusion can occur. The enemy of fusion is poor nutrition, nicotine and other substances that restrict blood flow, and movement. Any kind of movement where bones are fusing is going to prevent the fusion from happening. And then you just get scar tissue like we saw today. All right, what questions do we have?
So one question about the plate. If the plate is too long, what implications will it bring? Will it reduce movement or cause pain?
If the plate is too long, let me show you what I'm talking about. Okay, you all see that metal plate there? Okay, good. So when the plate is too long, the top of the plate, for example, let's pretend the top of the plate's too long. It's going to come up here, higher up, and it's going to affect the next disc up. All right, you can see the next disc is right there. You don't want this metal plate pushing on this disc. This is mobile, this is immobile. So something like that's immobile is just going to rub on the disc and cause it to fail. So you want the plate to be exactly as you see it here. The screw hole should be at most at the middle of the vertebral body and really closer to the end plate. So you don't want a plate that's too long because that's going to cause the plate to rub on the next disc and cause the next disc to wear out quicker. And then you get adjacent segment disease.
Okay, next question is, what is the difference between EBL and today's procedure?
What's the difference between
I guess the disc laser repair.
the Deuk Laser Disc Repair?
Yeah, and today's procedure. That's
All
what I'm
right,
trying to say.
well, no problem. So here's the basic problem that we're all dealing with, a herniated disc. Bone, cushion between the bones, herniation right there. Okay, here's the view the surgeon has, right here. We have this view of the disc. See that? That's what you saw today, right in the middle, and I actually went in there and I started scraping out the disc. What we don't have is the side view, which would be nice. So what every surgeon does is they scrape this whole disc out just to get to the back where that herniation is. Okay, you see the herniation back there? They really want to get to that, but they have to go through that to get there. And that's what we did. We went through that crack. That crack is the disc space. We scraped out the disc, we had the crack. At the back of the crack is the spinal cord and the nerves, okay? So what the Deuk Laser Disc Repair does is we go through the skin with a little 4mm cut. We don't do all that dissecting you saw in the beginning. We leave all the natural tissues alone, and we go in with basically a coffee straw through the disc. That's how big it is. And we get to the herniation in the back, and I zap it away, just the herniation. I leave the rest of the disc alone. So there's no metal, there's no fusion, there's no artificial disc. It's the best surgery in the world for a herniated disc. Okay, that's why we do it. Because we had to take all this disc out in the front and in the middle of the disc, now we have a gap. We had to put the spacer in there, the plastic spacer, and do a fusion with a metal plate. Okay, so once you're taking the disc out, the whole disc out to get to the piece in the back, you either got to fuse it with a cage and a plate, or you got to put an artificial disc in, one or the other.
Okay. And now we have one last one as a story. I've been told that my C4-5 and C5-6 is narrowing, being that I have lots of pain in the area. The neurosurgeon says that it does not need surgery right now, though it worsens down the line. He spoke about replacing discs and other discs. So in the meantime, what should I use to take care of that?
Well, so this is one of our viewers who has a herniated disc at C4-5. I assume you're having pain in your neck. So what kind of symptoms can a herniated disc in the neck cause? The most common symptom is neck pain. Pain right inside there, and it hurts, and there's just no way to get rid of it. And that's the kind of pain that we treat here at Deuk Spine Institute. We get rid of that pain for you. The other thing a herniated disc can cause, besides the neck pain, is pain coming up the back of the head, right in here. It's called occipital headaches. And we call those cervicogenic headaches because they come from the cervical spine. So neck pain, cervicogenic headaches, and then pain shooting down your arm. Pain shooting down your arm is radiculopathy. Weakness in the hand or arm. Numbness and tingling. If any of those symptoms are due to a pinched nerve in your neck, including neck pain or headaches, we can fix all of that with surgery. I would not wait. Pain, radiculopathy are bad things. You don't want to live with them. A lot of surgeons tell you just to live with it. I don't agree with them. We can fix it so easily these days. There's no reason to live with pain. It literally changes your psychological makeup. Pain, chronic pain will change the way your brain works. And it makes you moody, makes you unhappy, it makes you not enjoy life. It makes you irritable, impatient, like me. No, seriously though, chronic pain is bad. If you're having this pain in your neck for more than 2 months, don't wait, go get it fixed. Problem is surgeons aren't going to fix your pain because they don't believe in operating on neck pain. They don't think they can fix it, they can't fix it, all right? They're taught to treat arm pain, not neck pain, arm pain. Weakness, numbness, tingling in the arm. So the thing the surgeon wants to know from you is there nerve damage causing arm symptoms? Is there spinal cord damage causing weakness in your legs and arms? If those two things don't exist, they're called radiculopathy and myelopathy. They don't exist and all you have is neck pain, they're not going to recommend surgery for you. You're condemned to live with neck pain and headaches because they don't know what's causing the neck pain and headaches. They don't know how to fix it. Okay, it's that simple. And we do at Deuk Spine Institute. That's what we do every day.
They have a follow-up to that they're speaking about putting steroids and epidural injections in her neck area and spine.
Mm-hmm.
Is there something I should be aware of with their plan to help me?
Yeah. So the good question, this patient has a herniated disc in the neck with neck pain and symptoms from the herniation. And those symptoms are inflammatory. It's from inflammation in the herniation right in the back there. They're talking about doing steroids, like a steroid injection. We call those epidural steroid injections. Nothing wrong with doing that. It won't fix the problem. It'll help ease the pain, maybe for a week, a month, maybe even at most a year. But your pain will come back again because the steroid injection is not fixing anything. All right.
And that is all, sir.
All right, we'll see you all for the next surgery. Thank you.